Hello, dear students. It's rather nice to continue to work with you. Today we will continue to speak about preventive work of district therapists. In previous lecture we talked about healthy lifestyle, about risk factors, how we can influence on health of our people to prevent some disease. And today we will continue, but we'll speak in more details about dispensarization, about screening checkup, and what we can do as doctors to save our patients' health. So, our today lecture plan. We will speak about concept of dispensarization, stages of it, different types of prevention examination. We will speak about groups of dispensary surveillance, about some criteria of effectiveness of dispensarization. We will speak about prevention and dispensarization of some most common pathologies with which people come to doctor. This is ischemic heart disease, hypertension, chronic gastritis, peptic ulcer, for example, and so on. So I will give you some examples for better understanding what dispensarization means. Dispensarization is from French dispensaire. It's a system of work of healthcare system and establishment, meaning active monitoring of patients' health, providing proper physical development, health promotion and prevention, prevention of disease using appropriate prevention, sanitary and treatment measures. The basis of dispensarization. Sure, dispensary methods work. Method of active surveillance of patients' health, of action of individuals. Look, here it's important to understand when we speak about dispensarization, it's not when we speak about uh, situation when person comes with some complaints, symptoms, and we make something, but mostly we are oriented for people without any complaints. But it's necessary to find some pathology among them, some screening tests and so on. I will speak about it in details and it will be more clear for you what dispensarization means. In other words, dispensarization is a method of work with healthy and ill individuals, a sense of which is exploring the health status of the population and further work with it. For healthy individuals, health promotion and preservation, primary disease prevention, active identification of individuals with risk factors is important. For individuals with some disease, diagnostic diseases at earlier, it's rather nice. So not when people come with some complaints, but before it. So in this case, dispensation includes preclinical silent stages of diagnosis of them. For example, screening test. Also include prevention of exacerbation, rehabilitation, so secondary and tertiary prevention. If you don't remember what secondary and tertiary prevention means, look the first lecture. The main aim of dispensarization is decreasing morbidity, mortality, hospitalization, invalidization, increasing lifespan, prolonging active longevity, improving quality of life, preserving workability. And dispensarization, it's not one moment methods. It's a continuous process that uses different types of therapeutic, social, sanitary measures and health education. So this is dynamic control, dynamic follow-up our patients. Maybe I use this phrase not in the first time, but in another word, in more simple way. Dispensarization, it is periodic health examination with primary, secondary, and elements of further prevention, including follow-ups. There are different stages of dispensarization. Individual evaluation of population health and define of groups of dynamic dispensary surveillance. healthy, practically healthy, and individuals with various disease. Annual health examination and establish minimum of laboratory and diagnostic tests. Later, I will describe you what should we do for people of different age and gender in our country. In your country, it can be differ, but I really hope that in your healthcare system in your country, people come not only when they have any complaints, but also for prevention screening and checkups. Because believe me, it's really easier to treat some disease in early stage in compare with condition when people suffer from some symptoms. Furthermore, truth examination and evaluation if people already need it. Uh, Also, another stage is development of and taking medical and social measures required for health promotion and preservation, dynamic surveillance afterwards. Annual analysis of efficacy and quality of dispensarization also necessary. And about all these stages we will speak. When we speak about prevention health examination or checkups, if we speak about individual level, it can be when person come to clinic, when sometimes we see that person didn't visit you during very long period of time, and here it's more than 1 year. We can call patient to come to our clinic, that it's time for checkups. Sometimes during home visit, I don't know if you have home visit in your country, but here there is such a possibility for people to call doctor to visit them at home when their condition not so severe, to call ambulance and be hospitalized, but it's not possible to come to clinic. Mostly we speak about all people who can't move normally after stroke, when patients suffer from severe fever and so on. And then we have preliminary checkups. For example, when you into university, you also visit a doctor not because you had any complaints, but uh, before applying to the job or army, when we speak about entering educational establishment, kindergarten, school, university, and so on, it's necessary to check if your health condition normal, uh, if education working will not cause any damage for your condition, or maybe it's dangerous for other people to communicate with you. So it can be different, and depending what exact job, what exact studying, different health condition can be contraindication for it. For example, for people who work rather intensive physically, contraindication for this work will be more in compare with office worker. And so, if we speak about mass, we speak about some screening, questionnaires, targeted according to some special groups, periodical, again for certain cohort. So, in our country, we have some regulation. In 2010, we had the main instruction, which changed particularly every 2 years, and now modification of it was made 2 years ago, which shows that there are some indication and for some type of work, so some ratio of profession holders applicants that undergo annual periodic health examination. For example, if we speak about student, teachers, medical staff, this periodic examination will be every year. Amount of this research will be different for each professions. For professionals with risk of being infected or spread of infection and parasite disease, for example, restaurant workers or doctors. We even have sanitary card where every year doctors write something, and without the sanitary card, a person can't work in this sphere. So individuals who are subjects of mandatory periodic health examination. Children in kindergarten and school, adult people, students for some work, fertile age women between 16 and 45 who have no more than one child, because we want to have more babies in our country, and surely we should save women possibility to have a baby for pregnancy, and it's why we give special accent for women of this age. Pregnant women, surely the same reason. Then invalids and people who participate in the Great Patriot War, it's a part of the Second World War. With every year, much of such people became lower, but we try to give as much as our attention to control their health, and surely we want them to live longer. So such people visit doctor, or doctor visits them every year, or not even one time. So we just give our respect for them, and surely we control their health. People who work in some place of work where there are some hazards, for example, noise pollution, air pollution, and so on, when condition of work can influence some disease in future. So-called decreed individuals, people who work in food industry, employees of public services, people who communicate with big amount of other people, special cohorts, also government officials, people who suffered from Chernobyl nuclear power plant accident. It's really catastrophe of our country, and such situation that great amount of ionization caused pathology more than 25 years ago. We see a complication even now. So we control condition of such people more attentively than others. All citizens of our republic have the right to undergo dispensary examination or to refuse. Surely a person answer for his health, but we should give such opportunity. And when we speak about dispensation of adults, it includes not only health examination, physical examination, dynamic surveillance, but also healthy lifestyle promotion. We give improve education about health for such people. We talked about it in previous lecture. Development of interest in and responsibility of individuals for their health. It's very important, because sometimes when a person not pay for doctor consultation, his motivation can be not so good, but we should give another motivation. The person should save his life, and when we improve knowledge about healthy lifestyle, it's really work. So when we speak about amount of tests, laboratory, instrumental method of research, it can be different according to the age of people. If we speak about citizens of Belarus, for people between 18 and 30 years old, we as doctors should make physical examination, full physical examination. Look, when you see patients in first time or in first time during this year, you make full physical examination. From nose, lymphatic nodules, auscultation, percussion, palpation, to the toe and the leg, so you should check everything. But then when person come in the second, third time during this year, physical examination can be not so full, but oriented what reason, what disease causes pathology. Except physical examination, we should measure blood pressure, no matter for what reason this person come to you. Body mass index calculation is necessary and not obligatory, but it will be rather useful if we measure waist circumference, because it also shows predisposition to some disease. If indicated, we make blood tests, urine tests, glucose level, make ECG, chest X-ray. If indicated, it's clear if we speak about chest X-ray once in 3 years. Expect people who work in medicine, except students, teachers, they should make chest X-ray one time in 1 year. In this situation, we make screening for tuberculosis and some another disease, lung pathology, which is necessary to find in the early stage. Gynecology examination for women, including breast examination, one time per year. Between 30 and 39, the same plus cholesterol level. If indication presents some family story and so on. After 40, everything that we already mentioned, and plus we calculate cardiovascular risk using score chart. I will speak about it a bit later. Also, we measure intraocular pressure. When we speak about gynecology examination, after 50 years old, we make mammography one time in 2 years. And urological examination included prostate gland for men, and plus PCA. This is test for screening for prostate gland cancer one time in 2 years, but after 61 every year. Fecal echo blood test also recommended. So all of this research we made for all people in our country, for citizens, no matter have they disease or not. So one more time: physical examination, blood pressure management, body mass index control. For people younger than 40, if indicated, ECG, blood test, urine analysis, glucose, and fluorograph or chest X-ray, gynecology examination for everyone. Plus, after 40 years old, we check PCA one time in 2 years, and after 60 every year. Mammography just for cancer. It's just for every citizen, no matter there are complaints or not. There are 3 dispensary groups. The first one, D1, the first, is a group of healthy people. It includes people without any complaints, no problem in anamnesis, normal physical examination, normal analysis, and prevention work with such group include health promotion, education about healthy lifestyle, and annual health examination. So we work with risk factors of some disease development, ask about smoking, alcohol use, inactivity, and so on, and work with such risk factors. And make all research that we already mentioned in previous slide, depending on what age of this person. This is the first group. The second group include particularly healthy people. This group about people with chronic disease, but in remission when during 5 years, last 5 years, was no symptoms, complaints, changes in analysis. For example, chronic pyelonephritis, but there is no pain, dysuria, there is no changes in analysis during 5 years. We can't say that person doesn't have this pathology, but he will be in this group. People with risk factors, with genetic predisposition, people who rather often recurrent suffer from respiratory pathology. Normally, we speak that adult person should suffer less than 5 times per year, even less than 4 times per year of respiratory pathology. Like if you catch cold 6, 10 times per year, surely your health is not normal. even without chronic pathology. People who recover after severe acute disease, for example, tonsillitis, pneumonia, glomerulonephritis, some trauma, some period after recovery, they will be under control and will be the second group. But some people have predisposition to some disease development in future. So when they recover, absolutely, they will return to first group. But sometime after, they will be in the second. So for this group, we make examination 1-2 times a year. Also prescribe all that minimum level of research diagnostic tests which we discussed for everyone. We should make more action for healthy lifestyle promotion. We should speak about individual features of health activities for this exact patient. We should change or at least speak about risk factors exactly of this person. So it's our work with such group of people. D3 include people with chronic conditions. There are two subgroups. The first, or D3A group, patients with different chronic disease with recurrent exacerbation, subcompensated, decompensated form, and D3B, these people who has invalidization, not temporary disability but constant. And surely we work with them in a different manner. If we speak about dispensarization, most common pathology with which we work in a patient department, this is respiratory pathology like a chronic bronchitis, asthma, bronchiectasis, lung abscess, COPD. We speak about cardiovascular pathology, ischemic heart disease, hypertension, gastro problem, gastritis, dyspepsia, hepatitis, ulcer, colitis, kidney pathology, joint pathology. Yes, and surely our management, our plan will be different, depends what sphere suffer this person. Very interesting group, frequently and approximately ill people who suffer 6 and more cases per year, and the summarized day when they ill, more than 40. Such people has very high predisposition to chronization, but also it can be caused by chronic stress, some immunodeficit condition. So if you see such people, you should check their condition better and compare with another healthy people. It's not a sign of pathology, but it shows a severe predisposition for it. So prevention work with people of different group. We should see such people at least 2, but mostly 4 times per year. Diagnostic tests will be also more common and spectrum of them will be wider. Sometimes we ask specialists, consult such people. We work with risk factor and about some another so-called healthy measures. We speak about work and rest regime. Sometimes we give some recommendation to work of this person if we see that it's influenced on its health. We speak about diet, physical therapy, some infection sites eradication, is there is Helicobacter, for example. It also can influence on health condition of this person. Prescribing some medication, drug, sanatorium resort treatment. By the way, if we speak about resort treatment, resort is a territory which by climate, by nature condition can cause has a good effect on our organism. For example, if we speak about sea, some forests, some ionization, some special mineral waters, by natural reason, this structure can cause rather nice effect on our health. And sanatorium, it's medical establishment which based on research, which uses nature conditions plus some type of physiotherapy and so on. We use it to improve health of our people. And for example, Belarus is very rich for sanatorium and resort. We have some rather unique places. For example, in Seligorsk, we have salt production fabrics, and also there are some sanatorium on this church. It's very nice for people who suffer from asthma and another respiratory pathology. Another method is planned hospitalization. Maybe it's called ridiculous, but sometimes some surgical manipulation can improve health of this person. For example, if we speak about bladder disease, kidney stones, and so on, some manipulation can improve quality of life and improve condition of this person. Rational work placement, if person suffers from hypertension, ischemic heart disease, working at night not rather nice, or working when there is no mental work but rather severe physical activity. So it's also necessary to remember. If you see that there is chronic severe condition, maybe it's necessary to send person for special commission, which will make decision if there is signs of invalidization or not. So it's also rather important. If we make some manipulation with person, we should analyze if it's effective or not. So there are some criteria of activity of dispensarization of every person. For example, there are no signs of exacerbation of disease. It's person stay in remission. Times of temporary disability became shorter. For example, if person suffers from osteoarthritis, when he suffers from pain, when he can't move normally, he stay at home, not go to work. And if you see that after your treatment, after dispensarization, this period of losing possibility to work became shorter, it also shows that your work is rather nice. Elevation of clinical stages of disease. Absence of primary invalidization, if person not have constant disability, yes, if he can continue to work, it's really rather nice for this person. Elevation of invalidity group. We have three groups. The first is the light form, when person can do some work at home, but mostly he can't work, or his place of work should be not rather difficult for this person, without physical activity, mostly mental, not at night or something like this. The second means that mostly person can work but can do something at home, he can't control himself. In the first group, it means that person needs somebody who can care about him, he can't do it by himself. And if you see that disease became not so severe, person can care about himself, surely it shows that we do everything correct. Another, if we speak not about individual level, but when we speak about group, population level, percent of people who are under our control, in ideal situation should be about 100. So all people should be under this population, healthy or with some disease. But really, I hope you understand that it's not possible that all people will go to doctor at least one time per year. But normally we have more than 80% of our population under dispensarization, sometimes in some years even more than 90. Percentage of employed, it means people who continue to work but under our control. Surely we make accent on such group. Percentage of dispensalization people in every disease, for example, how many people who suffer from stroke or ischemic heart disease under dispensation? Surely it should be close to 100%. Percentage of exacerbation of the main disease in all patients with this pathology. Number of days and cases of temporary disability of each diagnosis in dispensary group during last year. Average case duration and so on. Also, we use such statistic analysis as frequency of primary invalidization for every 100 people under dispensarization, mortality in dispensarized group in percent, and for every 1,000 people, invalidization, and so on. And every doctor makes such analysis for people whom he consult. So every doctor, every organization, and in the end of year, we make such analysis about all healthcare system in our country. Now we will speak about some rather common pathologies, and for dispensarization we will do according disease. And we will start speak about tonsillitis. Firstly, we will speak about streptococcal tonsillitis because it's one of the most common form of this pathology and can cause a lot of complications. First of all, if you make a diagnosis of streptococcal tonsillitis, adequate treatment, it's primary prevention of acute rheumatic failure and early diagnosis of post-streptococcal glomerulonephritis. In our country, we control this person during 1 month after recovering. Every 2 weeks, we ask patient to come to us, make physical examination, and also we take blood tests, urine analysis, and make ECG, and repeat it every 2 weeks. So, for example, a patient suffers from tonsillitis. You prescribe amoxicillin for him. He uses it about 10 days. After 2 weeks, you will ask patient to come to you to repeat this analysis, and then 1 month, so 2 weeks after last visit, you will see this patient one more time. It helps us to find the first changes which can help us to prevent severe complication. Especially it's important among young people, especially when we speak about children, teenagers, youth. Complications happen more often among young in compare with old. Also, we can recommend vitamins, probiotics, eradication of infection sites, and no physical exertion during 2 weeks. If we speak about pupils or students, we give a special document to school or university, and person can avoid physical training classes, or we give some documents for adults that they shouldn't go to gym if they have, if they go usually, yes. So during 2 weeks after tonsillitis, person should avoid physical exertion. Next disease which we should discuss, this is pneumonia. Duration and frequency of surveillance depends how severe this pneumonia was, but mostly we speak that reconvalescence happened during 1 month, and then during 1 year we will control this person 2 times. We will repeat X-ray if a person not recover faster than 1 month. So person suffer from pneumonia. If after 1 month we see some changes on X-ray, we will repeat it 1 year later. In this period, we will send person to blood test, sputum analysis, if person not recover as fast, we see prolonged form of pneumonia. We repeat chest X-ray and blood analysis 1 month later after full recovery. And pulmonology consultation also indicated if we see prolonged form of pneumonia. Rehabilitation, rational and temporary work placement. If person work in refrigerator, for example, when temperature always low, or with severe physical activity, it's better to give some recommendations that sometime after pneumonia, employee should change place of working, healthy living, physical therapy, massage, only if person not suffer from fever, some breathing technique, breathing exercises, influenza prevention, not when there is acute form of pneumonia, but when person starts to recover. And some term result treatment also recommended for this person. Next disease, it's not acute in compare with previous, but chronic. We will speak about one of the most common pathology, atherosclerosis and ischemic heart disease. There are some risk factors which influence on speed of this pathology development. Firstly, we speak about dyslipidemia when total cholesterol high, low and very low density lipids higher than should be, and opposite high density lower than it's necessary. By the way, for people without cardiovascular pathology, total cholesterol should be lower than 5.5 millimole per liter. Among people with ischemic heart disease, it should be lower than 5 millimole per liter by European guidelines and lower than 4.5 by American guidelines, but at least it should be lower than 5.5 for everyone. If it's higher, we speak about hypercholesteremia. Low density lipids should be lower than 1.7 for everyone. If person has a lot of risk factors, such from ischemic heart disease, diabetes, it should be lower than 1.3 millimole per liter. Hypertension, blood pressure should be lower than 140 to 90. By American guidelines, nowadays, hypertension is everything that's higher than 130 to 80. Everything that's high, this is hypertension. By European guidelines, hypertension is when blood pressure higher than 140 to 90. But no matter what classification we use, it's better when it's 120 to 80 and lower. We should control glucose level because high glucose or insulin resistance increase risk of atherosclerosis and increase inflammation, so ischemic heart disease will develop faster. Smoking, alcohol abuse influence on atherosclerosis development. Physical inactivity. In previous lecture, we spoke a lot about this moment. If person not do a lot, or at least enough, risk of atherosclerosis became really very high. Overweight and obesity. It's like pandemic of 21st century. So many people suffer from this pathology, and even overweight, not even obesity, influence on risk predisposition of this disease. Unhealthy diet. When person use a lot of saturated fats, sugar, high cholesterol, trans fat, fast food, surely it's not rather nice, and it's an increased speed of atherosclerosis development. By the way, when you eat a lot of simple carbohydrates, sugar, it causes atherosclerosis even faster in compare with products where there is high concentration of cholesterol. And emotional stress. Yes, there are data that hypertension develop faster among people who are under emotional stress, and it truly influence on ischemic heart disease development. If you notice that your patient has one or several risk factors, surely you will work research. Patient give him recommendation what he can change to decrease risk of ischemia conditions. And again, major risk factors which we mentioned can be modified by healthy lifestyle, physical activity, losing weight if there is some problem with it, with body mass. Decrease amount of alcohol that person use, stop smoking, use meditation or another way of relaxation. Sometimes it's necessary to use some drug. For example, if you speak about hypertension, to decrease level of blood pressure, it's necessary to use drug. By the way, by statistics, particularly 30% of people who suffer from hypertension didn't know about it. And every third person who know about this diagnosis, that he suffers from it, doesn't use therapy constantly. So it's very important to describe person how it's important, what is necessary to do. If you speak about dyslipidemia, sometimes it's not enough to change nutrition, but it's necessary to use some drug. And one of the most common group of drug which we use is lipids. Is there is insulin resistance even without diabetes? Lifestyle modification is one of the best things which person can do. It works even better than metformin. But if person can't control himself, you can add metformin even without diabetes. So as you see, healthy lifestyle or combination healthy lifestyle together with some additional medical measures can improve prognosis and prevent ischemic heart disease development. There are some group of people who in higher risk of atherosclerosis development. For example, patients with established ischemic heart disease diagnosis or atherosclerosis or because of another location, for example, in the brain, in brachycephalon atherus, and so on, who needs lipid lowering therapy, not only drugs. Patients without symptomatic ischemic heart disease, but with higher risk factors according to score. This is systemic coronary risk evaluation chart, which use 5 indicators: age, sex, smoking, systolic blood pressure level, and cholesterol level. People with rather bad family history of ischemic heart disease, and this score table you can see here. For example, here you can see the level of blood pressure, different tables for men and women, for smokers and non-smokers, and according cholesterol level and age. And rather nice to show this table for people with some risk factors. For example, usually it works rather nice for people when you show like your age is 50, but because you are a smoker, because you not control your level of blood pressure and cholesterol level, you have the same risk factor as 65 years men without these risk factors. Yeah, so it's rather nice for motivation, for improving motivation for our people to change something. We use this chart for people even without ischemic heart disease. It's just for people who in risk of it, and to show patients and also for your usage, you can see how some different risk factors influence on cardiovascular disease development. It can be different among women and men, and by the way, women suffer from cardiovascular disease not so common compared with men. Usually we have about 10 years difference, like 50 years old men have the same risk factor of ischemic heart disease development as 60 years woman. There are a lot of parameters why women suffer from cardiovascular disease when they're older in compare with men. But in the first position, estrogen level. Before menopause, estrogen protects our vessels from atherosclerosis, but after menopause, organisms want to increase the amount of estrogens and start produce cholesterol more and more. And when there is no answer, estrogens continue to be low, organisms not stop, and hypocholesterolemia appear. There is no protection effect of estrogens, and atherosclerosis develop. Except that parameters that indicated in the chart, risk can be higher if person has some conditions. For example, obesity, especially when we speak about central obesity, when waist circumference more than 90 centimeters. If you remember, we already, if you remember, we already discussed in previous lecture about measuring of waist circumference. But I will repeat, one more time about these parameters. When we speak about overweight, we look not only for body mass index, it should be lower than 25, but waist circumference. For men, it should be lower than 85, for women, less than 80 centimeters. And waist-hip ratio should be less than 0.9 for men, and for women, less than 0.8. If it's more, we speak about abdominal obesity, central obesity. And this condition increases risk of insulin resistance, hypertension, and ischemic heart disease development. People with strong family history, not only one person, but a lot of members of families suffer from cardiovascular pathology. Socially deprived individuals and people with some ethnic minorities, they have higher risk that they can suffer from ischemic heart disease early in comparison with another. People with diabetes, if there is diabetes, they have very, very high risk of this pathology development, no matter what the level of cholesterol, blood pressure, and so on. People with low high density lipids and increased level of triglyceride, fibrinogen, level of inflammation, which can be found by increased level of high sensitivity reactive protein. When there is chronic kidney disease and glomerular filtration rate not rather nice, especially when it's lower than 60. So there are some extra risk factors, but most important, which we use in school: age, smoking, blood pressure level, cholesterol level. So we use this chart. Now one more time about some levels among healthy people. Total cholesterol should be lower than 5 or 5.5. If it's lower than 4, it's great. But for people without cardiovascular disease, it should be lower than 5. For people with cardiovascular disease, it should be lower than 4.5. Low density should be lower than 3 for everyone and lower than 1.3 for people with high cardiovascular risk. High density should be more than 1.1 for everyone and more than 1.3 for people with cardiovascular risk. Triglycerides should be less than 1.7 millimole per liter. And we calculate the ratio between total cholesterol and high-density lipid. It should be lower than 4. This is coefficient of heterogeneity. If there is such situation that total cholesterol normal by high-density lipids rather low, atherosclerosis can develop. So the ratio is also important. If total cholesterol level higher than normal, it's recommended to use statin therapy with moderate and high cardiovascular risk. And we look for low density lipids. It should be less than 3. But for people who already suffer from cardiovascular disease, it should be lower than 1.3. By new guidelines, by American guidelines, it's less than 1.3. By European, less than 1.8. American guidelines has stricter rules in compared with Europeans. Low density lipids, if they lower, is better. Here in the slide, you can see some examples of the most common used statins. In the first position, rosuvastatin is one of the most strongest statins. Ratio of effect with atorvastatin is 1 to 2. It means like 5 milligrams of rosuvastatin has the same effect as 10 milligrams of atorvastatin. The maximum dose of rosuvastatin 20 milligrams, of atorvastatin 80 milligrams. Lovastatin and simvastatin, they're a bit weaker, they're not so strong when compared with first two drugs, and mostly we use first two, rosuvastatin and atorvastatin. Omega-3 fatty acid also can decrease total cholesterol and increase high density, but in dose 4 grams per day. For healthy people to decrease, if you don't want to prescribe statins, it's possible to prescribe omega-3. Fenofibrates. In dose 140 mg per day, it's rather effective to decrease total cholesterol and especially decrease triglyceride level. Fenofibrates decrease triglyceride better than statins do it. About nicotinic acid, nowadays we don't use it, but earlier it was used, but in such dose, it usually causes itching, redness of skin, and it's not so strong in compare with previous group of drugs. So in some old recommendation or in some national recommendation guidelines you can find it, but honestly we don't use it in our practice because there are so many side effects and we have better drug. So just to prevent complications, it's better to use statins, omega-3, fenofibrate, nowadays also ezetimibe, rather popular, which catch cholesterol in bile and prevent absorption of it. So mostly we prescribe this group to decrease level of statins. Next moment, when a person suffers from ischemic heart disease and angina pectoris happen. There are different functional classes. We will speak about stable angina because unstable means that it's pre-myocardial infarction condition, and we speak not about dispensarization but about emergency care. If we speak about angina, we should see this person at least 2-4 times per year, depends what functional class. If we speak about first, second functional class, it will be enough to visit 2 times per year. If we speak about fourth functional class, we will see person every 3 months. If it's necessary, we can send person to neurologist, psychotherapist, 1 time per year, cardiologist, if there are indications, but mostly family doctor work with people who suffer from angina. We make blood tests, urine analysis, biochemistry, which include lipid profile, glucose, protein, liver enzymes. Then we make ECG at least twice per year. Firstly, when we diagnose functional class and angina at all, we make stress tests, exercises testing, for example, bicycle or treadmill test, chest X-ray if necessary to make for such people. Is it possible? It's nice to make ultrasound of heart Halt ECGs mean monitoring during 24 hours. We see how, look, when we make a resting ECG, when person just laying, and there is no attack in this moment, ECG will be normal. If person suffers from angina without exercises, in most cases, ECG will be normal. And just to see how it changed during routine daily activity, we make Holter. Person go to home, he not stay in the clinic, in outpatient department, do everyday activity, and then he write diary where he mention when he wake up, go to bed, eat, doing some exercises and so on, and then we analyze an ECG and what he wrote in a diary. About management, rational work placement is rather important, without night duties and so on. We spoke about risk factors, and to work with such factors, it's also our task. Diet, then some medication, which include beta blockers, calcium channel blockers, metabolic therapy, prolonged form of nitrates, ACE inhibitors, or angiotensin II blockers, statins, antiplatelet therapy, and surely again sanatorium resort treatment, some type of relaxation also recommended to such people. If we speak about hypertension, risk factors of it. For men, more than 55, for women, more than 65, but it's necessary to add that about 25% of population suffer from hypertension. It's not only a disease of old people. Even after 30 years old, a great amount of people already suffer from this pathology, but with age, the risk of hypertension, of high blood pressure became really catastrophic. Family history, but here it's necessary to ask in what age relatives start suffer. If grandfather starts suffering from hypertension at 70 years old, it's not family history. Mostly we ask about young period when person starts suffering from cardiovascular pathology. Smoking, it causes hypertension very fast. Dyslipidemia, obesity, diabetes, these factors of hypertension, I hope you know about it. But most people don't suffer from any signs, pathology caused by high blood pressure. Most people even don't notice it before they measure blood pressure. But inner organ suffers, and mostly we speak about kidney, heart, vessels, retina, brain. These organs suffer firstly when blood pressure high, and decompensation of some pathology in these organs cause death and complication and so on. So high blood pressure can cause left ventricular hypertrophy, which we can find by ECG during ultrasound research, and in severe cases we can find by chest X-ray. We can find changes of arteries by ultrasound or X-ray tests. We can see atherosclerosis, sclerosis of aorta, for example. Kidney damage we can check by creatinine clearance. For this, for understanding what clearance is necessary to make blood test, urine analysis, to check the function of kidney. It's also necessary to check if there is proteinuria. Firstly, start from microalbuminuria. Also, it's nice to make ultrasound research of kidney. Also, it's rather nice to make some screen tests for neurology changes. Because reflex can suffer, but not in the beginner stage. Some diseases which are associated with hypertension. Firstly, cerebrovascular system. Stroke, transitory ischemic attack happen more often among people with hypertension. Myocardial infarction, angina, chronic heart failure happen more often. kidney disease, some peripheral arterial disease, dissection, aortic aneurysm, atherosclerosis, retinopathy, diabetes mellitus. By the way, rather often we see such complication as erectional dysfunction, and surely it decreases quality of life of people. Here you can see a table how we analyze the risk of cardiovascular pathology depends what level of blood pressure. If we speak about some risk factors, for example, age, male sex, smoking, dyslipidemia, glucose intolerance, obesity, family story of cardiovascular disease, some asymptomatic organ damage which we find during some diagnostic tests like one more time left ventricular hypertrophy, retinopathy, vascular damage, microalbuminuria, and so on. You look what risk factor does this person has, then look for the level of blood pressure, and then find what risk of cardiovascular pathology at this person. For example, we speak about 50 years old man who is smoking. So here we see two risk factors. Then if he has family story of cardiovascular disease, 3 risk factors. So here, for example, you see more than 3 risk factors. Then look for his blood pressure. For example, his blood pressure 160 to 100. Okay, this is the second grade. You look high risk. Or if person already has diabetes, chronic kidney failure, already suffer from coronary heart disease, suffer from myocardial infarction, no matter what the level of blood pressure, he will be in very high risk of cardiovascular pathology. Also, we use score. I already mentioned it when we discussed ischemic heart disease, but it also showed. And some words about dispensarization. One more time, we see this person 2-4 times per year, depends on what risk of cardiovascular disease of complication. One more time, if person in low or moderate risk, you will see this person 2 times per year. If he in high risk or in very high risk, you will see this person 4 times per year. Also, rather often, we send person to neurologists, ophthalmologists to see what happened with retina, is there is retinopathy, or if it's possible for you to make ophthalmoscopy, GP also can make. If we speak about people with high and very high risk, cardiologists also should consult this person at least